right, let's jump right in. We are in the middle of a revolution in cancer treatment, thanks to this incredibly powerful class of drugs. They target a pathway that's fundamental to cancer growth. But, and this is a big but, this revolution is opening up a whole new frontier for endocrinologists. You're the ones now on the front lines, managing the really complex and often severe metabolic side effects.
And that right there is the core tension we're going to unpack. These drugs, they are absolutely brilliant at stopping cancer in its tracks. But the very same mechanism that makes them so good at killing tumors also throws a wrench into some of the body's most critical metabolic and hormonal systems. And that creates a really fascinating and frankly urgent clinical challenge for all of us.
So, to really get a handle on the problem, we first have to understand the target itself. What is it about this specific signaling cascade that makes it such a prime target in the world of oncology?
Well, the PI3K/ACT/mTOR pathway isn't just a pathway. You have to think of it more like the cell's main operating system. It's a central hub that gives the basic commands: when to grow, when to divide, and crucially, when to live or die. It is absolutely fundamental to how a cell functions.
In this pathway, it's kind of got a dual personality. In a normal, healthy cell, it's just doing its job, regulating metabolism and keeping things running smoothly. But in cancer cells, this entire system gets hijacked. A dysregulated pathway is what puts the accelerator to the floor, giving cancer all those aggressive traits we want to stop. So you can see why it's such an ideal target for a new therapy.
And that dual role leads us straight to the central problem, the double-edged sword. When you successfully block this pathway to fight the cancer, which is the goal, you're also, by definition, blocking its normal, vital functions in healthy tissues all over the body. The on-target effect is precisely what creates the off-tumor problems. And we've got a whole toolkit of drugs designed to do this, each one hitting the pathway at a slightly different spot. You've got your PI3K inhibitors like alpelisib, your AKT inhibitors like capivasertib, the mTOR inhibitors, which many of you are familiar with, like everolimus, and even dual inhibitors that hit multiple points at once. They're all aiming for the same cascade, just from different angles.
And you know, this quote from the literature really hits the nail on the head. The side effects aren't just a nuisance. They can become so significant that they actually undermine how effective the drug can be, sometimes forcing a dose reduction or even stopping the treatment entirely.
Okay, so let's roll up our sleeves and get into the nitty-gritty of this metabolic fallout. For endocrinologists, this is where it gets really interesting, as we unpack the precise mechanisms behind two of the most common complications you're going to see.
So, the first domino to fall, and honestly, the most predictable one, is insulin resistance. Because this pathway is so deeply woven into glucose metabolism, when you inhibit it, you're almost guaranteed to disrupt insulin signaling to some degree.
So how does this actually happen at the molecular level? Well, it's a chain reaction. The therapy itself causes oxidative stress, which flips on these stress kinases, JNK and IKK. What do? They go and phosphorylate IRS1, but at the wrong spot, an inhibitory site. This effectively jams the insulin signal, so cells can't take up glucose properly. And the clinical data on this is striking. We're talking about a jump of up to 50% in insulin resistance markers in some patients.
And you don't just have to take my word for it, you can literally see this happening in the lab. Take a look at this data. As the dose of the inhibitor, gedatolisib, goes up, you see the glucose uptake in these breast cancer cells just plummet. It's a clear, direct, dose-dependent confirmation of the very mechanism we're talking about.
Now, after insulin resistance, what's the second major metabolic hit you can expect? Dyslipidemia. The liver's lipid metabolism is also tightly controlled by this pathway. So when you block it, you predictably get changes in cholesterol and triglycerides.
And again, there's a clear mechanism. These drugs can suppress something called AMPK, which is like the master energy sensor for the cell. When you suppress AMPK, you're basically taking the brakes off the cell's fat production. Key enzymes for making fat, like ACC and FAS, go into overdrive. The result? A big increase in triglyceride and cholesterol synthesis. And the data confirms it, showing up to a 30% rise in liver triglyceride levels.
But the story doesn't stop with metabolism. The impact goes even deeper, leading to direct endocrine toxicities. You see, these targeted therapies can have a really profound effect on the hypothalamo-pituitary gonadal axis, which brings us to another huge clinical challenge: drug-induced hypogonadism. Just look at that number for a second. 80%. That's the prevalence of hypogonadism that was found in a case series of male patients on crizotinib. This is not some rare side effect you read about in a footnote. For some of these agents, it is pretty much the expectation. And as you can see here, this is a class-wide issue.
Take the mTOR inhibitors like everolimus. They're hitting the same pathway. You see prevalence rates over 50% in patients with metastatic renal cell carcinoma. So why does this happen? Well, the thinking is that the PI3K/mTOR pathway is absolutely crucial for GnRH neurons and pituitary function. So when you inhibit it, you can mess with the whole HPG axis, disrupting hormonal signaling and leading to central hypogonadism.
Now, this creates a massive diagnostic dilemma. I mean, look at these symptoms of hypogonadism: weakness, mood changes, muscle wasting, trouble concentrating. What does that sound like? It sounds exactly like cancer, or just cancer-related fatigue. Because of this huge overlap, it can be so easily missed by everyone, the patient and the oncology team included.
And all of this brings us to a really critical clinical crossroads. To use these powerful cancer drugs effectively, we have to build a stronger bridge between oncology and endocrinology. It demands a more holistic approach that looks beyond just shrinking the tumor.
So for you, the practicing endocrinologist, what does this actually mean day to day? It really boils down to a few key, actionable things. We need baseline and regular checks on HbA1c and lipids. For at-risk patients, we need baseline and follow-up testosterone levels. And maybe most importantly, we need to be vigilant for these masked symptoms and work hand in glove with our oncology colleagues for proactive, not reactive, management.
And this is really the big question we're all left with, isn't it? The future of oncology is all about precision. But true precision medicine means managing the whole patient's physiology, not just the tumor's molecular profile. Answering this question and doing it well is going to be the absolute key to unlocking the full life-saving potential of these incredible therapies.